Good evening, everyone. Good morning. We have audience and we have speakers that comes from across the globe, so it can be any time for our speakers and for our colleagues. Welcome tonight to this webinar and a symposia on COVID-19 and cardiovascular effects. Over the last 2 years, we learned a lot about the acute cardiovascular complications and clinical presentations of COVID-19. As a cardiologist and clinicians, we faced the different scenarios of acute presentations of cardiovascular in cardiovascular medicine of COVID-19. And still there is a lot to learn from as we go, especially the long-term cardiovascular effects of this pandemic and of this virus. So we conducting this webinar to learn from our experts more about it. So during this webinar, we have expert speakers who are involved in the care of these patients, of this population. They will share with us their experience from research and from bedside. So on behalf of you and on behalf of the Emirate Cardiac Society, I would like to thank our speakers for their valuable time and for participating in this webinar. Our speakers tonight, Dr. Peter Liu, Chief Scientific Officer, University of Ottawa Heart Institute, and Professor of Medicine, Cellular Molecular Medicine, University of Ottawa. We have Dr. Annie Varkus, Advanced Cardiovascular Care Center, Texas, US, and Chief Cardiologist. And also Dr. Hussein Heshmet, an intervention cardiologist from Fujairah Hospital in United Arab Emirates. And also we have Dr. Yusuf Al-Attar, consultant cardiologist and imaging cardiologist practicing at SSMC in Abu Dhabi, UAE. Also, we have Dr. Seema Noor, who is an intervention cardiologist at SSMC and SKMC. As I said, we have a diverse panel and diverse speakers with a lot of experience and a lot of knowledge that we will be sharing with you over the next 2 hours. I will remind you that this is a CME event and it's an accredited event. Another point I would like to remind you that you can post your question and answers during the webinar in the chat box and also in the question answer area, and we will, I will work on prioritizing them, and we'll try our best to answer all these questions. Last, I would like to thank our colleagues from Pfizer for the support on this event. So we'll move ahead and to the first talk, and to Dr. Peter Liu and his talk, which is SARS-CoV-2 variants, heart injury, vaccines, and myocarditis, pandemic to endemic. Peter, please.
Well, Assalamu alaikum, and thank you so much, and thanks for the wonderful invitation and the introduction by Dr. Al-Zubaidi and also the Emirates Cardiac Society. And I certainly have a number of colleagues in the UAE and always enjoy my visits. And sorry, we are doing this virtually, but delighted to have a chance with the illustrious panel members to share with you some thoughts on COVID-19 and the heart. And I will give the initial introductory talk, and then followed by Annie and Hussein. And is the slide okay? Yeah, okay.
It is okay. Yeah. Go ahead, Peter.
Okay, so thank you so much. Yeah, so we certainly know that, and it's still a surprise that in fact, COVID-19 is still with us, and this is more than 2 years already since the original description back in December 2019 from Wuhan, and there are now 370 million cases worldwide and over 5.5 million deaths. So this definitely is a major impact in terms of health everywhere. And including, for example, in Canada, there are over 3 million cases in total in the last 2 years, with 33,000 deaths. And just today, we have 16,000 new cases. And a lot of this is obviously due to the new Omicron. And in the UAE, there are 838,000 cases with over 2,000 deaths. And there are a number of active cases as well, but certainly appears a vaccination has been effective, and the UAE has, really a very good control effort, which is fantastic. And vaccination certainly decreased the severity of the outcomes, including the Omicron, but the new variant, including the new subvariant BA2, is now spreading, and so of course the story is still evolving. And we certainly have seen the impact of the variants in terms of the SARS-CoV-2. And we start out with the Alpha variant. This is the data from the US. You can see that's the first wave there. And the more severe cases were associated with the Delta wave during the last summer. And when just people thought that we are over, the Omicron has now taken over in many parts of the world. And fortunately, it's somewhat less severe, but nevertheless, it's extremely transmissible. So many people are affected by it. And this is a big, big challenge. And so we actually were involved in the research of SARS-CoV-2 right at the beginning, because one of my former trainees became the dean of the medical school at Wuhan University. And so we were looking at this new condition very much right at the beginning, because it was a big scientific puzzle. Initially, the government was trying to hide the cases, and that actually led to more deaths. And so we were happy to see that subsequently there is open sharing of data, especially the sequence of the virus, for example, and also the case profiles, and led to a number of collaborations. And for example, we have actually compiled the initial cases and look at their epidemiology and a number of publications. This is one example, for example, looking at the interaction of diabetes as the risk for patients with COVID-19. And you can see this series over 7,000 patients, and that the patients with diabetes has very much 3 times the increase in mortality. But even when we look at the patients with diabetes, those with well-controlled diabetes has much better outcome than those with poor control. And this is very much the theme that we have seen with certainly SARS-CoV-2, in that there is a major interaction with the cardiovascular system, and that the patients with cardiovascular risk factors like hypertension, diabetes, obesity, or presence of cardiovascular disease, whether that's coronary artery disease or heart failure, have much a greater propensity and also worse outcome. And indeed, this has been well documented in a number of studies. This is just one example of a meta-analysis looking at the risk of the presence of many of the cardiovascular complications in terms of the risk for severe COVID-19 outcome. And you can see that the presence of cardiovascular disease and hypertension or diabetes generally confer anywhere between 1.5 to over twice the risk. And this is also similarly replicated by congestive heart failure, cerebral vascular disease, or chronic kidney disease. And I think this confers very much our experience. And even with Omicron, patients with these conditions are the ones that tend to end up in hospital or in the ICU. And we have also initially documented the tempo of development of the disease and the cardiovascular complications. Fortunately, with Omicron, that the cardiovascular complications are much less frequent, but nevertheless, they still do occur. And so you can see that the virus is very infectious, and it engages the ACE2 receptor, for example, in the nasal passages, and it will proliferate. And generally, one becomes infectious within 2 to 3 days. Certainly with Omicron, that is very much the case. And the peak replication may take about a week afterwards. Most people will recover, but however, there will be a small proportion of patients who actually go on to have much greater immune response, leading to cardiac injury, release of, for example, biomarkers like high sensitive troponin, and also evidence of inflammatory response that is exuberant. And in severe cases, that's when the patient can actually develop organ complications, including cardiac damage. And there is now more data to suggest that, in fact, some of these inflammatory triggers are individually dependent. So some of this could be genetic or could be other factors of prior exposure, et cetera. And that the virus, once engages the receptor, can trigger inflammatory response. And it's a failure, particularly of either the sensing, proper sensing of the presence of the viral particles, and so that you have the incorrect immune response or prolonged immune response that actually leads to the severe disease. Of course, the one aspect that particularly SARS-CoV-2 takes advantage of and may have major implications for cardiovascular conditions because of the fact that the SARS-CoV-2 and in fact, most of the SARS-CoV viruses take advantage of the ACE2 receptor. So keep in mind that the ACE2 is actually an enzyme, and it actually is a good enzyme. It converts angiotensin 2, which is the 8th amino acid peptide, to angiotensin 1,7, which is actually the good vasodilator part. And so ACE2 is very important in counterbalancing the ACE1 that we have. And it's present also on the surface of cell membranes, like the endothelial cells, myocytes. And the SARS-CoV-2 take advantage of the presence of ACE2. It will internalize into the cell, but takes the ACE2 with it. So the ACE2 is actually temporarily disabled when the virus infection is taking place. This actually leads to an imbalance of ACE1 and ACE2 because there's a decrease of ACE2 presence, at least for a duration of the infection. There is decrease in angiotensin 1,7, increase in angiotensin 2, which of course is the vasoconstrictor, is the pro-inflammatory agent, increase oxidative stress, and it participates in the inflammatory response. And so there were big debates, folks may remember during the early days whether ACE inhibitor ARBs are safe or not. There are rationale, we can see that, with the increase of the ACE angiotensin 2 production, that one should consider ACE inhibitor, but there were others who are worried that the ACE2 receptor may actually increase when you actually take ACE inhibitor ARB. And so certainly from the data we have analyzed, it suggests that in fact, the patients who are on ACE inhibitors or ARBs did better, but this is retrospective, and this is obviously potential at risk, for bias, etc. And so this is why we actually have applied for funding, and currently is conducting a global trial, and it's called COVID-RASI trial, in which we ask the question of whether ACE inhibitor ARB are beneficial or not beneficial in patients with documented COVID-19 infection. So in this type of situation, patients with COVID-19 infection were randomized either to start on ACE inhibitor ARB or on standard care in which they are not on the agent, and to compare their endpoints 28 days and 1 year. So we are proceeding with this study at the present time. We have about 400 patients. We probably need to continue this for another 4 to 6 months before we have all the endpoints in place. But we do know that in addition to the fact that the virus engages the nasal passages in the airways in terms of ACE2, but the ACE2 in fact is present obviously in cardiovascular system in large numbers. And not surprisingly, then the virus in fact is distributed throughout the body and is present particularly on the endothelium, and which can lead to endothelial inflammation and increase thrombotic complications. In addition, it can actually lodge in the vasculature in the heart as well, leading to cardiac dysfunction. So we do know that patients who are infected with COVID-19 are at higher risk for large vessel thrombotic complications such as stroke, such as myocardial infarction. And I heard, one of the cases coming up will actually involve these type of scenarios. And obviously, this is a major concern when patient has multiple conditions taking place at the same time. But also, this can affect the myocardial function, leading to myocarditis like setting or cardiomyopathy. But it can also lead to cardiac arrhythmias, atrial fibrillation, but also ventricular arrhythmias. And some patients end up, requiring ICDs, etc. But patients with cardiac dysfunction will need to follow up, and this is where I think the longer term complication, Annie is going to discuss this in the second lecture. Look forward to that. In addition, for patients who are hospitalized with COVID-19, can actually demonstrate in addition to pulmonary complications, the cardiac complications, as evidenced by the release of biomarkers such as troponin. In fact, we look at the high sensitive troponin release in patients with COVID-19. It can be present anywhere between 15 to 30% of the patients. And generally, the presence of troponin release does portend a poor prognosis. And so those are the patients that will require more intense follow-up and more careful monitoring, particularly in terms of oxygenation and cardiac function. COVID-19 does actually affect the heart, as we mentioned earlier, but it probably is not the classic myocarditis in that we mentioned earlier that the virus does attach itself particularly to endothelial cells or the parasites, and also the inflammatory cells, so that it is present in the myocytes, but it's not actually the primary target. And this is why we see so much of the macrovascular and microvascular complications. But it does actually promote a significant amount of inflammation. And you may mention, the fact that one can see inflammation on the cardiac MRI scan, for example. And so that it's a bit of an atypical myocarditis, but keep in mind it does actually occur, with COVID-19. And but it is more frequent than the vaccine-induced myocarditis, which we'll talk about momentarily. And indeed, there has been documentation of the fact that COVID-19 can induce cardiac inflammation using, for example, the classic Lake-Louise criteria, in which Dr. Matthias Friedrich and ourselves have described earlier. And but it does bring forward the concept that, in fact, COVID-19 does affect the heart and can actually increase the signals in terms of inflammation, for example, in terms of T2 mapping, but also, in terms of increased extracellular volume through T1 mapping. And of course, this is very much in the news, especially if some of the sports figures or young athletes, ending up, for example, with positive scans and affecting the heart. The other complications to the vascular, as I mentioned earlier, that can be due to the inflammation leading to increased PI1, of course, angiotensin II induce that as well, and the leading to microvascular complications, for example, involve cardiac dysfunction as well as renal dysfunction, but also macrovascular diseases such as myocardial infarction and the stroke. And these tend to occur, for example, in younger patients than more traditional myocardial infarction or stroke. And the predictors for thrombotic events include elevated D-dimer, older age, hypoxia risk factors. And the active 4A attack trial suggested that in moderate risk patients, anticoagulation will be helpful. And I know Hussein will actually discuss it in more detail, and this more or less sets the stage for that. However, interestingly, in patients with severe state in the ICU with organ dysfunction or severe organ failure, anticoagulation, in fact, is not beneficial in that type of setting. So the patient's risk level and the stage of disease development is very important in this decision making. In terms of a patient who's in the hospital with COVID-19, the treatments are still somewhat few, even though they are increasing all the time. And supportive therapy obviously is extremely important. And so remdesivir has been shown to decrease hospitalization with a trend towards reducing mortality. And the best study is obviously the recovery trial that showed corticosteroids, particularly patients whose hypoxic, are extremely helpful in terms of reducing mortality. And now I think most people learn that we try to avoid mechanical ventilation early and try to use high flow oxygen tools and therapeutic anticoagulation, as we mentioned earlier. And so now there are a number of newer medications. I think the most exciting one is the one on the left column. That's Nirmatrelvir and Ritonavir, which is a combination of HIV drug with the antiviral, or the trade name is Paxlovid. And this is really exciting because it's actually an oral antiviral agent. And it has been shown to be very effective in terms of reducing the risk of hospitalization or mortality. And so the major advantage is that it can be used as an outpatient setting, but it needs to be started within 5 days of positive viral signal. So it is very much a race with time. And the downside, however, is that it has major drug-drug interaction. And it has major interaction with a number of cardiovascular drugs, such as clopidogrel, amiodarone, and many of the medications we tend to use. So one needs to be very careful in terms of watching out for that. And I won't talk about the others because they are intravenous. So the sotrovimab is probably the only monoclonal now still being used because it's the only one that seemed to be effective against Omicron, but it's intravenous. And remdesivir, as I mentioned earlier, is again used mainly in the setting of patient who's in hospital. And the last agent is also oral, similar to Paxlovid by Merck, but its efficacy is much lower. So I think people tend to use it only if drug interaction is a major issue. I won't go over the details there. And so, of course, the major game changer has been the vaccination. And so a variety of vaccines have been available. I know that in UAE, for example, I think the Sinopharm or the collaboration with China has also been effective in terms of bringing forward the vaccine availability. And worldwide, certainly the mRNA vaccines are very, very popular and has been very effective as being a game changer in terms of protecting the world against certainly severe disease. I think that's the most important message so far, even for Omicron, that it's still effective. But there's no question that the virus is getting more clever all the time. So I'm glad to see that newer vaccines, targeting the newer variants are now being tested. And so, of course, the major challenge is the fact that the virus continued to mutate at a very high rate. Big surprise, I think people didn't expect that. And so SARS-CoV-2, the Omicron variant compared to the original has over 50 mutations, and the 32 of them is actually on the spike protein. So it becomes much stickier on the ACE2 receptor, and that's why it's so transmissible, and also escapes the immune surveillance. And so this is why it is continuing to do this. And there's worry that the BA2 subvariant is even more effective in doing that. Fortunately, the vaccines that's available today appear to still protect against the variants, even including Omicron, even though the spike protein has mutated so much, because the T-cell response appears to be still stable across the variants, and that contributes to the amelioration of severe disease. And but I do think that as time goes on, we will need to evolve the preparation so that we can actually keep up with the virus, so to speak. So the last thing I just talked very briefly is the myocarditis related to the mRNA vaccines. And so this, now with vaccines, there's always a very, very low incidence of myocarditis, and particularly earlier story related to smallpox, but that's a kind of a different type of vaccine. But it's starting March last year when there was a global vaccination effort that a signal in terms of cardiac inflammatory reaction to COVID-19 begin to be reported first in Israel, and then the CDC, and certainly in Canada, we begin to actually see cases as well. Keeping in mind that it's still a fairly rare condition, but nevertheless, it has a fairly distinct pattern, which is kind of unique. And so we compiled the data and just recently published this data from both the WHO as well as vaccine registries. And so you can see in panel A that the distribution of risk individuals is very distinct. And so number one would notice that, it's a younger individual, certainly people under age 39, that tend to have the vaccine related myocarditis. But the sex distribution is also very distinct. The orange color or the pink color is male, and you can see that it's really the young men who actually get this complication 3 to 4 times higher than females. And if you actually look at the panel B, in terms of pathology, this appears to be unique to myocarditis. You can see the blue color, the pattern for myocarditis, and you can see this distinct age distribution versus pericarditis, which can also occur, tends to be more evenly distributed through the different age. And the panel C is in terms of symptoms, and not surprising, is chest pain, fever, elevated troponin. It can have a positive MRI scan as well. And these tend to occur on the panel D here in terms of myocarditis within the first 2 to 3 days. In fact, after vaccination, average is about 3 days. And there have been a number of publications, and certainly the data from Israel has been most, I think, comprehensive. But this is the one that just published a few days ago in JAMA, and this is the US CDC data. And again, give us the same assurance that it's the same pattern. So on the panel on the left of the vaccination case reports in terms of myocarditis, for the Pfizer-BioNTech vaccine, on the right is the Mrna vaccine. And you can see that the peak is about 2 to 3 days following the initial inoculation. And then the other thing you notice is that the lighter blue is the second dose, the darker blue is the first dose. So majority comes after the second dose. So it appears to be repeated exposure give you the highest risk in this type of setting. There are, of course, a lot of speculation potential mechanisms, but this appears to be unique to mRNA vaccines. And so one thing that's very true is that the following mRNA vaccines, you have very, very high level of the spike protein that's actually circulating in the blood. Of course, this is the intention, so you can activate the immune system. But this spike protein probably interact with the ACE2 receptor and does actually contribute to the inflammation in those at risk. It's dose related, likely. Pfizer has 30 micrograms and Mrna has 100 micrograms of mRNA. So Mrna is a little more efficacious, but the risk of myocarditis is exactly 3 times that of Pfizer as well. So you can see that it's likely related to the mRNA preparation somehow. And it has a memory trigger, because it's much more common on repeated doses rather than the initial first dose. And there is a decreased risk with longer interval between doses. So this may be one strategy to actually decrease the risk of developing myocarditis on subsequent boosting. And there's definitely sex interaction mentioned earlier, and there's also age as well. So it tends to be young men who tend to get this. And there is a interaction with ACE2 receptor, and we're studying this very actively at the moment. And currently we have a registry in Canada that looks not only at the clinical outcome, we also study family members, so we can actually have a case control setting. And we also look at the imaging and immune profiling. So with Omicron still, with us and the BA2 evolving, is there an end to this? A lot of people say that maybe this is the last variant. Certainly we hope it is, but we need to be always vigilant. This is just the paper from Nature yesterday. And, to say that, yes, COVID-19 may become endemic, which means that it maintains kind of equilibrium with the population, but it doesn't mean that it's harmless. It still means that we need to be vigilant, and that the virus can continue to evolve, And it's not just a common cold, because it certainly have much more severe outcomes. And so I think in the future, still effective vaccination, as you folks are doing in UAE, that's going to be super, super important. And so just in summary, then the COVID-19 is a major global health challenge, and we haven't seen this before. And it's certainly a major lessons in terms of, virus infection, intersection with the host, but also the importance of vaccine and the importance of science driving forward these solutions. And SARS-CoV-2 certainly uses the ACE2 receptor, and likely has this particular relationship with cardiovascular risk and cardiovascular patients in terms of complications. And so we do know that treating cardiovascular disease, in fact, is very important. I didn't show the data, but with the diabetes, we get the hint, but in fact, it's very consistent that if the underlying cardiovascular condition is well treated, the ACE2 receptor, in fact, goes down, and that the patient has a much lower risk. So that's very important. Remdesivir, anticoagulation, steroids are important for hospitalized patient, and the vaccine is still effective even against the Omicron. And of course, this will evolve over time. Keep in mind that the vaccine-induced myocarditis is real, but it is very rare. It's about, sort of between 1 to 2 per million individuals. So it's fairly low, and it's about 10 times less than COVID-related myocarditis. And it has a very distinct pattern as well. And so this is something that we need to keep in mind. So vaccination is still important, but being aware of this condition is good to look after the patient. And the oral agents like Paxlovid and other antivirals, I'm sure will come along, will be very important as part of the armamentarium. And so even though we're entering endemic stage, hopefully soon, but it is still not safe. So we still need to be vigilant. Thank you so much for your attention.
Thank you so much, Dr. Liu. I mean, this is a great highlights and very informative lecture. I'm sure there's a lot of questions that's going to come up. Already we have some questions out there, but I would prefer leaving them towards the end. Again, I would encourage our colleagues, the attendees, to please post your questions, and we will take care of it at the end of this webinar. So now we'll move to long-term cardiovascular effects of COVID-19, and Dr. Annie Varosich, Advanced Cardiovascular Care Center, Texas, US, and a chief cardiologist. Dr. Annie, please.
Very good. Oh, Dr. Liu, what an excellent presentation, and very exciting to be here. Dr. Al-Zubaidi and I have been talking about this for quite some time, and it's just a real pleasure to give this lecture along with you. So I want to just start. Some of these things that I'm going to talk about are kind of co-joining what Dr. Liu has said, and then we're going to take it to a different place. So potential effects of coronavirus on cardiovascular system was reviewed way back when all of this started. We were all wondering, and these slides, and I want to just thank my colleagues, Dr. Zvonimir Krazier from the Texas Heart Institute, and Dr. Douglas Harrington, the author and inventor of the pulse cardiac test, which I'll talk about in a little while. So there are a lot of potential effects of this virus, as you've seen with Dr. Liu's slides. And I love this slide because it just kind of encompasses everything, you know, from direct vascular infection all the way to myocarditis, like he was talking about, and myocardial depression, heart failure, increasing oxygen demand, heart failure, MIs, strokes, you name it. It's a smorgasbord, right, of things that can happen with this virus. And publications started coming out immediately about how this virus was similar and different from the previous SARS-CoV and MERS-CoV. And it showed that these patients didn't have to have cardiovascular disease to end up with these types of hematologic thrombotic problems. And we saw large vessel stroke as a presenting feature of COVID-19 in the young. and it was getting very dangerous very quickly. And we were all in a confusion, right? Because we know that the causes of venous thrombosis are stasis and vessel wall injury, hypercoagulability. But this peripheral arterial or venous thrombosis is different than coronary thrombosis. And we had to kind of look at what this coagulation cascade. Dr. Liu had talked about this in great detail, but this fibrin and degradation products were very interesting. And what happened, some of these became clottable and some were not clottable. And it all depended on what happened at the vascular endothelium, the damage that occurred. This fibrinolytic cascade is very important to understand plasminogen to plasmin and subsequent fibrin and fibrin degradation products. So this pi1 that he was talking about is important, and it'll come back later on as stopping this process. And so if you're not going to lyse this, you're going to be having problems with the clotting. And so we know the fibrinolytic system. We can see the clottable and non-clottable fibrin fragments listed here. And this goes, of course, into the research. This is Dr. Liu's area. I'm just a clinical cardiologist, but I love talking about all of this and how we can prevent the problems down the road. Epithelium, and that's what I really love to look at. Hold on just a second. I hope everybody's still seeing me because it said my internet connection was bad, but we're good. And we,
we have a pause here, Annie. So
yeah, we had a pause. Okay, are we good now?
Yeah, we're good.
An increasing thrombus. So here we have the patient, the uninfected population, all the way up to COVID-19 death, and all have potential for increased risk of thrombus, and increasing age, bedridden status, inflammatory responses, DIC. All of this can happen at any stage of the game. But we know that, as Dr. Liu was saying, VTE prophylaxis is very, very necessary. And we'll talk a little bit about that later in certain segments of this triangle. So DIC and ICU thrombotic very early in the game, we were seeing a lot of pulmonary embolism, CVVHD clotting. People were just in all areas were clotting and having thromboembolism in spite of prophylaxis, in spite of the treatment. So the risk factors, of course, acute illness, chronic renal failure, COPD, heart failure, and we saw a host of hemostatic abnormalities. Microemboli and pulmonary microemboli, myocardial injury, D-dimers were sky high. And the clinical presentation, of course, DVT, pulmonary embolism, MI, CVA, DIC. Something very interesting to me is vaccine-induced immune thrombotic thrombocytopenia. Now, in late February 2021, this was observed post-AstraZeneca and Janssen vaccines. And so we have COVID-19, and then we have the COVID vaccine. And the syndrome was happening after COVID-19 vaccine. And some of these patients, of course, may also have had other causes of thrombosis to cloud the picture: antiphospholipid syndrome, cancer patients, associated thrombus and thrombocytopenia there, DIC, and thrombocytopenia purpura. So the pre-vaccine induced thrombotic thrombocytopenia term was used for those patients who were coming in with severe headache. I saw a lot of these patients complaining of headache post-vaccine with negative imaging, and some of them subsequently may become positive and have become positive. So it's something to remember about that vaccine, even though later we'll talk about, of course, the risk-benefit ratio, of course, favors the vaccine. So critical illness and thromboembolism risk. You can see in COVID, the risk, the VTE prophylaxis, even if they had VTE prophylaxis, still a very high risk of having thromboembolism. And across the board, heparin users versus non-users, it looked like heparin users had somewhat better mortality rates, but we were still seeing thromboembolism with the use of heparin. And this was a wonderful paper about thrombotic and thromboembolic disease implications for prevention, therapy, and follow-up. So the suggested considerations for prevention and management of thrombosis among hospitalized patients, we see, and Dr. Liu talked about some of this as well. And risk stratification should be performed for all inpatients. And if they don't have contraindications, they should receive prophylaxis, except in those very, I think Dr. Liu, you mentioned some of that, the very, very critically ill may have more problems than not. For hospitalized patients with COVID-19, presence or absence of DIC and hepatic or renal disease should be considered for appropriate choice of the anticoagulant agent. And we're going to look at which agents should be used. Now, this is management of acute coronary syndrome. This is very interesting. I think this was a worldwide phenomenon. We didn't know what to do with these patients. They were COVID positive and they were having acute MIs. So optimal medical therapy and dual antiplatelet. And many of them were receiving fibrinolytic therapy versus PCI because of cath lab inability to take these patients. And so it was really a quandary for quite a long time about what to do with in the management of acute coronary syndrome. The Hematologic Society's guidelines for VTE prophylaxis and monitoring, coagulation testing on presentation, very, very, very important. PT-PTT, D-dimer, fibrinogen platelets, all of these things are highly important in checking, especially that D-dimer. I've seen many patients admitted without a D-dimer. And it's just amazing to me. Elevated fibrinogen and D-dimer greater than 1,000 indicating worse outcomes and need for admission. So if they're admitted, the testing frequency should be daily. If that D-dimer is rising, that D-dimer, remember, is greater than 1,000, very poor prognosis for the patient. So all hospitalized patients should receive pharmacologic prophylaxis. And if their kidneys are functioning well, low molecular weight heparin. If the creatinine clearance is less than 30, then unfractionated heparin. And multi-organ failure with the D-dimer elevation is still towards unfractionated heparin if no contraindications. But again, this goes into that area of, as Dr. Liu mentioned, do they benefit or are they doing worse? Now, I have a lot of slides, so I'm trying to stay on time. All right, good. So we've talked about that. So these are current unanswered questions. How long are the patients with COVID-19 prothrombotic? These are the long-term problems that we're starting to see. How long do we continue anticoagulation? And how do we take care of them when we send them home? And what is the role of the DOAC post-discharge? So I wanted to give you a clinical scenario. I know we have clinical scenarios coming later, but I'm going to give you a vignette. 47-year-old male that I saw here in the UAE came to the ER with complaints of chest pain since yesterday evening. He had palpitations and he was in atrial fibrillation with inferior ST depression. So he was ruled out for MI. He drinks, he's a smoker. He had negative troponin, but he was admitted and he went to the cath lab. In the cath lab, we found mild non-obstructive CAD, but myocardial bridging. And so he had an implantable loop recorder inserted, and he was placed on low pressor and Eliquis. Now, he had had COVID several months prior and had these palpitations, but no one could actually find anything until we actually he came to the hospital with atrial fibrillation. He's had multiple episodes of long-standing atrial fibrillation, lasting several hours in duration, and he's on the schedule for ablation. So that brings me to the point of how do we find this silent atrial fibrillation, and because this man was in Afib and he didn't actually know it. And what are our modalities in 2022? And this kind of takes it to a different level of understanding of, we have these EKGs and these patients are post-COVID, they're coming in and they have an EKG and they're in sinus rhythm. they may be having some chest discomfort, some shortness of breath. We have multiple modalities here in the UAE, as well as around the globe, to evaluate these patients beyond the standard EKG. And I'm talking about Holter monitors or MCTs or implantable loop recorders. So it's very important because of the risk of atrial fibrillation for stroke. And a lot of patients who come in with cryptogenic stroke, the cause of this stroke is 20 to 40%. Cause of ischemic stroke remains uncertain, even though complete diagnostic evaluation in 20 to 40% of cases. So the Chad's VASC score is important, but other risk factors are important as well. And one of those risk factors, I believe, is COVID-19. They're a high risk for atrial fibrillation. About 25% of hospitalized patients had atrial fibrillation. So this is showing evaluation for cryptogenic stroke with event monitors, and it showed the proportion of patients in whom AF was detected increased with increasing duration of ECG monitoring. And I'd like to challenge everyone here, all the cardiologists, to remember that 24-hour or 48-hour Holter monitoring may not capture atrial fibrillation. As I saw a patient today in the clinic, I was running towards giving this talk, and I had seen this patient, and he had Afib. And again, no one had found this because I had put an event monitor on him 5 days ago, and now we know that he has paroxysmal atrial fibrillation, and he's post-COVID. So this is showing an extended ambulatory ECG monitor. This was a study-AF, single center study about a wearable patch. This was a certain type of patch, but there are many types out there. And it showed that AFib was detected in 5.3% of patients, but AT and AF in 11% of those patients. And those are totally asymptomatic patients. So if you want to Holter monitor, fine. But if you want a world free of wires, think about a wearable biosensor that we actually have here in the UAE, and it's a Holter Connect, and that actually connects wirelessly, and the patients are loving it. They're seeing it here in the UAE now. So just wanted to tell people that it's so important to look for arrhythmias, and beyond arrhythmias, think about the patient with endothelial dysfunction. When we talk about myocardial infarction, we were always talking about vulnerable plaque, endothelium, what happens in this whole heart attack scenario. But now with COVID-19, the risk is so much higher. And we use here in the UAE a test called a pulse cardiac test, and it's not a lipid test, it's an inflammation test. So I think, Dr. Liu, you'll be very excited. You probably know about this test, but it's there in the USA, and we brought it here to the UAE. It's like checking the engine light, all right? And everyone knows about their cars, check engine light. What about our hearts? And if we look at this pulse cardiac test, it's helpful in disease prevention, in disease management. We use it in the US and here in patients who have hypertension or hyperlipidemia, or now with COVID, oxidative stress is a huge player beyond vascular disease from the usual insulin resistance and hyperlipidemia and high triglycerides. COVID-19, think about oxidative stress and what's happening at the endothelium. That's the target organ, right? And about the ACE2 receptor, almost had and of our body, 4,000 to 7,000 meters squared. So when the disease process is inflammation, the body is responding to injury, free radical injury. I'm going to go to C-reactive protein. Some of my colleagues say, well, we do C-reactive protein. Well, that's good. Sensitivity is 35%. The pulse biomarker sensitivity 73%. So I challenge you to read about pulse and look at the accuracy of it. Many doctors here in the UAE are using that, and of course in the US with 99% sensitivity and specificity for endothelial injury. We know the biology of atherosclerosis. Now you know that with COVID-19, it's taking it to another level, way beyond what we knew about the necrotic core and fibrous fatty area. That's where the pulse score is actually measuring the markers of inflammation. This is an example of what it looks like. Don't be scared. You get a score and you know that the patient's at risk for having some type of cardiovascular event. And when I was doing pulse score in the US 5 years ago, and suddenly in November of 2019, I started seeing pulse score tripling in my patients. And I called, and it kept going and going, and I called the lab and I said, do you have some reaction problem with blood? What's happening? They said, no, we're seeing this across the board. And later, of course, in March, we knew that there was this SARS-CoV-2, and we kind of equated that. Now there's a host of data with regard to COVID-19 and the pulse test. So the receptors, as Dr. Liu so elegantly talked about, the ACE2 receptor is similar to the ACE, an enzyme in the renin-angiotensin system, and a target for the treatment of hypertension. So this ACE2 receptor is what SARS-CoV-2 loves. So the consequences of COVID-19 and how pulse cardiac tests can help are endothelial damage. We see severe pneumonia, followed by this cytokine storm, or this overactive immune response that no one could get a handle on. Unexpected causes of death in patients, especially those less than age 50, due to blood clotting, caused by endothelial damage, blood clots, heart attack, stroke. It's all an endotheliopathy. And so we really need to start respecting, I think, the endothelium much more than we do as cardiovascular doctors, and as internal medicine and family medicine. All of us need to understand that COVID can cause severe endothelial damage. Now look at the consequences of COVID vaccine: anaphylaxis, thrombosis with thrombocytopenia, Guillain-Barré, myocarditis, pericarditis, even death. So I wanted to just bring in a few patients who had COVID-19. What happened to them? Some of my patients in the UAE, one with chest pain and abnormal stress echo, admitted to ICU in Dubai, had cath revealing coronary aneurysmal dilatation, and again, inflammatory changes of the left circumflex artery. The one I talked about in the middle, who had the palpitations and found to have a rapid Afib. Another one below, post-COVID with severe fatigue, shortness of breath, echo showing pericarditis with pericardial effusion. And one post-COVID vaccine patient, 81-year-old male with diabetes and hypertension, very controlled. 5 days after the vaccine, developed slurred speech, facial droop, and admitted and found to have left MCA thrombus, and had emergent thrombectomy. Subsequently developed ARDS, multi-organ failure, and subsequently died. So which test will help with COVID-19 prognosis? The pulse cardiac test can definitely quantify the risk associated with COVID-19 injury to the endothelium. Samples can be obtained here and sent over to the US. If you're in the US or in other parts of Europe, the pulse score is available. D-dimer can predict hospital mortality. So the pulse cardiac test and D-dimer, I think, are the number one and number two things, because the pulse cardiac test actually quantitates 9 different markers of inflammation. And it mentions here CTAC, eotaxin, MCP3, fast ligand. Many of these have been tested in coronary artery disease, and now as well in COVID-19. And this was an abstract about mRNA COVID vaccines dramatically increasing endothelial inflammatory markers and acute coronary syndrome risk as measured by pulse cardiac testing. So, and this was in November 2021. So these were patients with 11 to 25% increasing in predicted acute coronary syndrome risk. Now, remember, the vaccine, the COVID infection itself has a 50 to 100% increased ACS risk. So we know this. We know that the pulse score increases, as I said, dramatically, like 2 and 3 times after the patients have had COVID. And many of the patients, when I first elevation of this, many of them didn't even know that they had COVID. And thank you for telling me I had 1 minute, because this is my last slide. Remember the check engine light. We know that there are tools that we have in our armamentarium to look at these patients and see how we can prevent long-term effects of COVID-19. Thank you.
So thank you, Dr. Ani. Thanks. That's great. So we'll move to, I don't know if Dr. Hussein is around. If not, we'll go to the cases. Already we have a good number of questions in the Q&A, and again, I would encourage our participants, to share with us their questions to the speakers. So Dr. Hussein still didn't join us. He had an emergency, and I hope he's well. So we'll move to Dr. Yusuf. Dr. Yusuf Al-Attar is a consultant cardiologist, specialized in cardiac CT and MRI, and he works at SSMC in Abu Dhabi. Dr. Yusuf, I know you have a good case. Please share it with us.
Thank you for the introduction, and good evening to everyone. I will present two cases in relation to the COVID vaccine that causes myocarditis. I want to emphasize that this is very rare, but when it happens, it's usually a very mild myocarditis type. This is first case, 23 years old gentleman presented to the ER with sudden left-sided chest pain radiating to the upper arm and a fever 2 or 3 days after receiving a second dose of the COVID-19 vaccine. Very young gentleman, previously healthy and had no upper respiratory tract infection symptoms for a while. And usually the patients present like this: chest pain with no other symptoms. ECG is normal. We take the patient on the same day to the CT scan. CT scan comes completely normal. All coronaries are normal. Patient would have been discharged with diagnosis of possible myocarditis, but because you will see here that the troponin kept rising a lot from 300, 400, 500, 900. So we decided to take him to the MRI. And the MRI, as you see, the ejection fraction on the left and the right sides are normal. Again, short axis shows normal ejection fraction. On the right side here, you will see, this is the T2 weighted images, steers images. You will see some edema only in one segment, inferolateral, basal inferolateral. And on the left side here, you have the late GAD images, and you'll see in the same segment, you have subepicardial late GAD enhancement that indicates towards very mild myocarditis, and the patient was fine and was discharged without any medications. Second case, there is only one case that was severe in our hospital. It's a 17 years old gentleman who presented to the ER with palpitations for a few minutes. And then when he stood up at home, he blacked out for a few seconds. He didn't have any chest pain, any shortness of breath, and he came directly to the ER. He's previously healthy, no medical history, and he had the COVID-19 vaccine, also second dose 3 days prior to his presentation. In the ER, his heart rate was 180, and his blood pressure was 114/70. This was the ECG. And he was diagnosed with ventricular tachycardia. We tried adenosine multiple times. We tried amiodarone. It didn't work. And finally, we went with synchronized cardioversion, and he was reverted back to sinus rhythm. Now, the troponin was slightly elevated, 38 and 82 after the cardioversion. So day 2, we take him to the CT scan, and as we see that the coronaries were completely normal, we gave his kidneys a rest and took him to the MRI on day 3. And as you see that the right ventricle is severely dilated with an ejection fraction on the right side of 20 to 25%. On the left ventricle is also affected with an ejection fraction of 40 to 45%. Here's another image, and as you would see on the short axis that the right ventricle is barely contracting. And here you can see the late GAD images. All the right ventricle is white. Remember, with late GAD, white is bad. And you'll see the entire right ventricle is fibrosed. Also, the entire left ventricle is fibrosed, but only 50%, not transmural, subepicardial late GAD, which is a very good indicator towards myocarditis. and therefore patient had an ICD implantation and for secondary prevention, and he was discharged the next day. Story doesn't end here because he came to our clinic 4 days ago, which is 4 months after his presentation, and he had a device check, and the device shows that he still has some slow VT, and now we added to him flecainide, and if it doesn't control his VT, then he might need an ablation. So before we end, I just want to shed a light on this. This is a paper from Israel, published in New England Journal a month ago, and it studied 2.5 million people vaccinated, and the estimated dose of myocarditis in 2.5 million was 2 in 100,000. And for those who like numbers, in 2.5 million vaccinations, only 50 myocarditis cases, 49 were mild to moderate, and only 1 was severe. Thank you.
Impressive. Thank you, Yusuf. I mean, this is a great case, and I think we'll get questions around it, but we'll keep those again to the end. We'll move to Dr. Sima. I know you have multiple cases on COVID myocarditis. So we had the case from Dr. Yusuf on the vaccine myocarditis, but you're going to prove to us that the disease itself is really bad when it comes to cardiovascular complications. Dr. Sima.
Yeah, hi everybody. Thank you. Thank you for this introduction. So I'm going to talk about COVID heart syndromes. As Dr. Zubaidi said, the COVID illness is much more worse than the vaccine complications. So I'm going to start with the first case. Um, 46-year-old man who has no known cardiac risk factors. He was known to have COVID and presented to a community emergency room with chest pain. His ECG is demonstrated below. It shows significant anterolateral ST elevation. So given the ECG findings, the patient was taken to the cath lab. This is just to show his chest x-ray. On the chest x-ray, you can see some pulmonary edema, but there is no significant pneumonia on the chest x-ray. His cardiac catheterization showed the right side. This is the right coronary artery. As you can see, it's nice and patent. It's a right dominant system. His left system, unfortunately, was not as nice as the right. So his left main is coming off here, and the left anterior descending artery is occluded, and so is his diagonal artery occluded, which was expected from his EKG findings. So the interventionist placed 2 wires, one in the LAD and one in the diagonal, and attempted to aspirate both vessels. Unfortunately, after multiple runs of thrombectomy, you can see that there's still no flow in the LAD or in the diagonal vessel. After multiple attempts of aspiration and again in balloon angioplasty, again, the final result showed no flow in both vessels. So the plan was, in view of the very high thrombus burden, was to keep the patient on tirofiban and IV heparin infusion for 48 hours and to bring him back for a relook to see if the clot was still there or if it had improved. He had an echo within the 48-hour period, which showed a large anterior wall MI with severe LV dysfunction. And unfortunately, a repeat angiography also showed that the occlusion was still persistent. So this is the first case demonstrating the effect of a large ST elevation MI with a very high thrombus burden and with no reflow as a result, even despite multiple aspirations and balloon angioplasty. Our second case is a little bit different. It's also a young gentleman. He's 35 years old. He has a history of hypertension for which he's not compliant. And he had, before presentation, he had a 2-week history of fever and URI symptoms. On the day of admission, several days before coming to the emergency room, he was having some sort of stuttering chest pains, which worsened, for which he came to the emergency room. This is his EKG upon arrival. It shows pretty much diffuse ST elevation, except for maybe lead 3 and AVF, but otherwise he has ST elevation all over. You can argue also that there's maybe some PR elevation in AVR and some PR depression in the other leads. But given his EKG findings as well in the active chest pain, we elected to take him to the cath lab. I'll just share with you briefly his lab data. His troponin was very elevated in the 2000 range, high ferritin, high CRP, high liver function tests, LDH, D-dimer, and he also had a chest X-ray and a high resolution CT, which showed no evidence of COVID pneumonia. And COVID PCR test was negative, actually, in this patient. But he had all the inflammatory markers, which suggest COVID infection. So this is his cath, which showed, if you can see, here's the catheter in the left system. His LAD is fairly big with good filling, and the circumflex is also large with good filling. So he had normal vessels, normal left corner system. This is another demonstration of his left anterior descending artery. It's a large vessel with good flow. And here's his right coronary artery. Again, he had patent arteries. I'll just show you his echo images. So in this parasternal long axis, you can see, so this is the right ventricle, left ventricle. You can see that there's hypokinesis in the anterior septal infralateral wall. Also, if you notice in this view, the RV looks a little big. We'll move on to the short axis view. Again, in the short axis view, there's global hypokinesis of the left ventricle. Again, RV looks a little enlarged. Looking at the apical 4 chamber view, the left ventricle is hypokinetic globally. RV also appears a little dilated in this view. So the conclusion of the echo was severe LV dysfunction with severe diffuse hypokinesis. Ejection fraction was estimated at 20%. Following this, given that he was COVID negative, we were able to actually do an MRI on admission, which was good. The MRI demonstrated biventricular impairment, ejection fraction of 28% in the left ventricle. The right ventricle was estimated at 27% with subepicardial leg gadolinium enhancement, typical for myocarditis. So I'll just point out to that area here. As Dr. Yusuf said, white is bad, and in this region as well. During his hospital course, after the diagnosis was made of myocarditis, the patient was sick. He was hypotensive, he was lethargic, somnolent, sick appearing. His inflammatory parameters were very high. There was a discussion done between the different cardiologists and the patient as well regarding the role of IVIG and steroids in this patient. And as we know, the data for it in adults is not as good as pediatrics, but given his deteriorating clinical status, the patient was initiated on this therapy. And he had a remarkable improvement within a few days. A repeat echo was done on day 9, which actually showed normalized ejection fraction. An MRI was repeated again after 6 months, and it showed no scarring and resolution of the findings before. So our third case also is very similar. It's a case of a young patient as well, a 29-year-old smoker with COVID infection who was in an isolation center. The patient had chest pain and was then referred to our hospital. His ECG, as you can see, shows ST elevation in lead 1 and AVL, and with some reciprocal changes in the inferior leads. Given this, the patient was taken to the cath lab. His cardiac cath showed normal coronary arteries. His laboratory parameters were notable for high liver function tests, elevated LDH and ferritin, and his chest X-ray again showed no COVID pneumonia. Echo, you know, the images were not great, but this is the best I found. This is the apical 4 on admission. And you can see that there's also diffuse hypokinesis, especially in the apical segments of the lateral and the infraapical wall. And what happened again with this patient, because clinically he was not doing well, he was treated with IVIG, I think, for 3 days and steroids. And this is his echo after just 1 week. Again, he had a remarkable improvement. Because he was COVID positive at the time and cardiac MRI was not done, one was done after 2 months, and it showed a pretty much normal cardiac MRI. So in conclusion, COVID-19 infection has a very wide spectrum of cardiac presentations with variable time intervals. So you could have had COVID a few months and then present, 3 months later with really bad symptoms. Cardiac manifestations are not necessarily related to the severity of disease or to having pneumonia. Predicting COVID-19 cardiac manifestations can be very challenging, as there's no clear guidelines on high-risk group or how to identify, the high-risk groups that will have cardiac manifestations. Unfortunately, in COVID patients, sometimes the normal diagnostic pathway of myocarditis is not feasible, such as getting an MRI when patients are COVID positives, and even sometimes CT is limited in those patients. Our cases demonstrate remarkable improvement in ejection fraction and clinical course within a short period of time. And to me, it's just very interesting if there's any data out there with respect to the role of steroids, IVIG, in COVID-19 myocarditis. And I think that, definitely more research is needed in the field. Thank you.
Thank you, Dr. Sima. Those are great cases. And I'm sure there's also questions that are posed, around those questions. Sorry, those cases. So before we move to the Q&A, I see Dr. Hussein Hashmat is online. I hope you're doing okay, Dr. Hussein.
Yes, sir. I'm fine. Thank you.
So Dr. Hussein is a consultant interventional cardiologist in Fujairah Hospital, and he is going to talk to us about NOACs, new oral anticoagulants in critical clinical situation, and that includes COVID situation. Again, if you have any questions, please post them in the Q&A.
Thank you so much, Dr. Zubaidi, for the kind invitation, and I'm glad to be here among this distinguished group of colleagues, and we're discussing a hot topic, which will come up and show up whenever there is a new wave. So today, these are my disclosures. So today I'll be talking about anticoagulation in high-risk situations. But before I go to that, I'll be shedding light on the most updated guidelines that we have on managing COVID-19. And these come from the NIH. And as you can see here, they were latest updated in 19th of January. So just a few days ago, they were updated by the NIH. And I'll focus specifically on our topic of today, which is anticoagulation. So what do these guidelines that were updated a few days ago tell us about anticoagulation or antiplatelets for patients with COVID-19? In hospitalized or critically ill patients, they are giving an advantage for heparin, especially low molecular weight heparin, over oral anticoagulants, regardless of which oral because of two reasons. Heparins have a short half-life and they have fewer drug-drug interactions. So dose and who gets a therapeutic dose, and there is a paradox here. For those patients who are not in the intensive care, they get a therapeutic dose heparin. And those who continue on therapeutic dose, they should continue for 14 days or until hospital discharge. So not in the ICU, but taking a full dose of heparin. Whereas those inside the intensive care, the recommendation is a prophylactic dose of heparin only. So there's a paradox here, and we can discuss that. So that's the first point. COVID patients, anticoagulation is parenteral, not the oral. So what about patients who are already on therapy? Let's start by warfarin. For those who are on warfarin, and because they are in isolation, so access to an INR is limited, so the guidelines recommend switching to a novel anticoagulant. That's another point to take. Of course, this does not apply to patients with mechanical valves, does not apply to patients with mechanical valves, LVADs, mitral stenosis, pregnant, antiphospholipid antibody syndrome. They should still continue on warfarin. For those patients who are already on an antiplatelet or an anticoagulant for another reason, then the guidelines recommend that they should continue this treatment unless contraindications or significant bleeding occurs. So these are the main points from the latest NIH guidelines on COVID management. So the topic of my topic tonight will be Afib in critical situations. So I chose 4 tricky situations. They coexist and overlap with COVID, and the decision of which oral anticoagulant may be refined. So I chose 4 situations: atrial fibrillation in the elderly, atrial fibrillation with GI bleeding, Afib with chronic kidney disease, and prophylaxis in cancer patients. And I saw a question from one of the attending colleagues: what's the relation between atrial fibrillation and COVID? And this is, of course, pertinent to our talk. As you see here, whenever there's an acute inflammatory condition, whether it's in flu or COVID, then atrial fibrillation comes in. And atrial fibrillation roughly is between 10 and 15% of patients who have a severe lower respiratory tract infection. So 1 out of every 10 or 1 out of every 9 patients are hospitalized will have atrial fibrillation. That's why this talk is also important. Is it risky? Yes, it increases the risk by 77 to 78%. So that's something we need to keep an eye on. And these are the agents that we use for patients with atrial fibrillation, the most handy agents: apixaban, dabigatran, rivaroxaban, with the different dose, standard doses and reduced doses, depending on the clinical situations. And I think you know that better than me. So I'll start by the first situation, which is atrial fibrillation in the elderly. And when we say the elderly, what comes to the mind? Drug interactions, polypharmacy, frailty, falls, comorbidity, cognitive decline, etc. So an atrial fibrillation with an elderly patient, what data do we have on apixaban? We know that the efficacy is more or less the same in terms of stroke prevention and systemic embolism, whether he's less than 75 or older than 75. But we know that in these patients, we're worried about bleeding. But you see this nice gradient here. As patients get older, then the protective effect of apixaban is maintained with a bonus, which is reduction of bleeding compared to warfarin. And this persists even up to the age of more than 80. Major bleeding is less, stroke is numerically less, and intracranial hemorrhage is significantly less. We've seen that with apixaban. How does it apply to the other agents? we know for sure that dabigatran 150 maintains superiority over warfarin, even in the elderly population. The same applies to apixaban, whereas rivaroxaban tends to lose this benefit. Looking at bleeding, which is our concern in the elderly, then apixaban across the board, less than 75, more than 75, is associated with a protective effect compared to warfarin. Looking at dabigatran, on the other side, as patients grow older, then the benefit in terms of bleeding reduction compared to warfarin. This is not only in the 4 classical studies of NOACs, but this has been replicated in real-world evidence. What we see here is that the stroke prevention is very solid with apixaban, regardless of the age. With dabigatran, we start to see some crossing of the identity line. With rivaroxaban, is preserved in terms of efficacy, but when it comes to bleeding, then dabigatran 110 is okay, but the best among them is apixaban, even in patients who are more than 80. So an elderly patient more than 80, when you're worried about bleeding and concerned about efficacy, it's apixaban, whether in randomized control trials and in meta-analysis. And I like this FORTA, which is an international consensus validation for the elderly, which drug fits the elderly. And they have 4 classes. A is indispensable, B is beneficial, and the only one that gets the label as indispensable for the elderly is apixaban. And this, of course, has been reflected in several document statements. In the ESC guidelines 2017, the first choice in the elderly above the age of 75 is apixaban. Then you think of dabigatran 110 and other agents. So for the elderly, it's apixaban. The second situation is GI bleeding, and we know that GI bleeding complicates roughly 1% of patients who are hospitalized with COVID. So if the patient is indicated for anticoagulation and he has GI bleeding, NOACs with GI bleeding is the Achilles heel of NOACs, because it's the area where NOACs did not perform well compared to warfarin. Several explanations, maybe because of a direct effect, or direct anticoagulant effect, or a direct caustic effect because of the acidic component of dabigatran. And as we've seen in RELY, we've seen in ROCKET, compared to warfarin, apixaban was associated with more bleeding compared to warfarin, and rivaroxaban was associated with more bleeding compared to warfarin. The only one which was associated with less GI bleeding was apixaban. Again, replicated in real-world data, the worst agent when it comes to GI bleeding is rivaroxaban and dabigatran 150, and the most protective agent is apixaban. In another real-world registries, it's apixaban and edoxaban. A point of caution, combining proton pump inhibitors with dabigatran, they tend to lower and reduce the effects of dabigatran, because dabigatran needs an acidic pH, and proton pump inhibitors increase the pH of the stomach. Again, reflected in the guidelines for patients with high risk of GI bleeding, it's apixaban comes first and then dabigatran 110. In the chest guidelines of 2018, the same apixaban comes first, followed by edoxaban and dabigatran 110. Again, confirmed in the latest 2020 guidelines on Afib, apixaban comes first and then comes dabigatran 110 milligrams. The third situation is atrial fibrillation with chronic kidney disease, and we know CKD is highly prevalent in patients with COVID, and acute kidney injury is also prevalent in COVID. We know that chronic kidney disease is a notorious condition. It's associated with increased risk of stroke and increased risk of bleeding. And as the eGFR worsens, then stroke is worse, all-cause mortality is worse, and major bleeding is worse. We roughly check the serum creatinine. We divide the creatinine clearance by 10. This tells you how frequent should we check for the serum creatinine. Initially, we thought that this was also a monopoly of vitamin K antagonists, but as time went on, we started to understand that warfarin is associated on its own with a decline in the eGFR. This is secondary most likely to vascular calcification, which is induced by vitamin K antagonist. Among the 4 NOACs that we have, the most dependent on renal excretion is dabigatran, while apixaban has the least dependence on renal excretion. And this can explain to us some of the findings that we saw in the randomized phase 3 studies. We see in dabigatran, as the eGFR worsens, then the tendency to bleeding increases. We see a clear gradient here. We didn't see that in rivaroxaban, but it's more or less the same as warfarin. In CKD with warfarin is similar to rivaroxaban. The only agent that was better than warfarin, even when the eGFR declines, again was apixaban, with a 50% reduction of bleeding compared to warfarin in patients with an eGFR less than 50. And probably the only agent that has reasonable evidence in patients with Afib and end-stage renal disease is apixaban. It was superior compared to warfarin, and the protective effect is similar to warfarin. This has been reflected in the latest 2020 guidelines on NOACs. The only NOAC that can be used across the board, even in the face of declining serum creatinine, even in dialysis, is apixaban. The 4th situation is venous thromboembolism and pulmonary embolism, and we know that roughly 1 out of every 5 or 10 patients who get with COVID will have a form of clinical or subclinical venous thromboembolic event. And we know from older studies, roughly 9 or 10 years ago, that we can use dabigatran, rivaroxaban, and apixaban. Each one of those agents has its own study, but it usually, with dabigatran, we need to give parenteral therapy for 5 to 7 days. Apixaban, we can start directly, provided that the patient is not sick. And the dose, of course, with apixaban is 10 milligrams twice daily. It's a loading dose in the first 7 days. Then we continue for 5 milligrams twice daily. With rivaroxaban, 15 milligrams twice. And then we continue 20 milligrams daily. What did these studies tell us? That the agents are all good. Rivaroxaban, dabigatran, apixaban, they all perform well compared to warfarin, and the bleeding has some small advantage compared to warfarin. That's why they get a class 2B recommendation using novel anticoagulants over warfarin in patients who have venous thromboembolic situation that is not a cancer related. How long should we continue? If the event is provoked, then at least 3 months. If the event is unprovoked, then we continue 6 months or even more. A note on venous thromboembolism with cancer, which agents we can use. We know that cancer is associated with increased risk of venous thromboembolism 4 to 7 times higher. And cancer is present even in 20% of patients who have an unexplained venous thromboembolic event. The risk of recurrence is high, with the highest incidence with pancreatic cancer, brain cancer, ovarian cancer, gastric cancer, bronchogenic carcinoma. We know that cancer is associated with a higher chance of DVT recurrence, even 3-fold increase in recurrence. And it's also associated with almost 3-fold increase in major bleeding. And we know that venous thromboembolism is worse during hospitalization event. In remission, the risk decreases. It gets worse with therapy, and it gets worse at the time of chemotherapy. And we had meta-analysis, a network meta-analysis that showed that comparing low molecular weight heparin with warfarin, which was the standard of care, then the bleeding is the same. However, we came to know more than 10 years, roughly 5 or 6 years ago, from another meta-analysis, mostly by the CLOT trial, that low molecular weight heparins are superior to vitamin K antagonists in cancer-related venous thromboembolic events. So the standard of care was low molecular weight heparin, but the problems with low molecular weight heparin is the discontinuation rate. So it was intuitive to think of novel anticoagulants to replace warfarin and low molecular weight heparin in venous thromboembolic patients with cancer. And looking at the subgroup of patients who had cancer from the VTE studies, we found that the signals are encouraging. And even there was a study with rivaroxaban versus low molecular weight heparin that showed that rivaroxaban was better in terms of prevention of recurrences compared to low molecular weight heparin, with almost a similar effect of bleeding. We also had a small study with apixaban versus low molecular weight heparin that showed that discontinuation was much better with apixaban and that recurrent events were also better with apixaban, but the study was small. So they thought of a bigger study. It's called the Caravaggio Study that enrolled 1,000 patients in 11 countries. Patients were cancer or pulmonary embolism were randomized to apixaban versus low molecular weight heparin. And as you can see, apixaban was non-inferior with a slight tendency for superiority compared to low molecular weight heparin, and the major bleeding was not different. So now we can use apixaban as a prophylactic after a venous thromboembolic event compared to low molecular weight heparin. Of course, the survival was not different. When should we continue? Probably the longer, the better. More 3 to 6 months or more than 6 months. What do guidelines recommend for cancer-associated VTE? 3 to 6 months, and they can continue indefinitely. So to summarize, these are roughly the benefits of each of our available NOAC in different situations. You can see that dabigatran, they are all good in terms of intracranial hemorrhage. Dabigatran 110 is better for bleeding. Dabigatran 110 is better than warfarin for stroke and systemic embolism protection. Rivaroxaban is better in terms of intracranial hemorrhage. Also, rivaroxaban has a vascular protective effect in terms of prevention of MI. It has some renal protective effect. Apixaban is superior to warfarin for stroke, intracranial hemorrhage, mortality, major bleeding, and it can also be used in patients with chronic kidney disease. So to recap, I hope I'm on time. In patients who are hospitalized with COVID, who are naive to anticoagulation, who have an elevated D-dimer, and they are sick and they are requiring hospitalization, prophylactic dose heparin for patients who are in the ICU, therapeutic dose heparin for patients who are less sick. For patients who are already on anticoagulation, we continue. We shift warfarin to NOAC, except in pregnant ladies, mechanical valves, antiphospholipid syndrome. The choice is guided by the clinical variables. Elderly, GI bleeding, chronic kidney disease, we can think of apixaban. Thank you so much for listening. I invite you to listen to my podcast. You can scan this QR code. You may like the content, and I'm ready for questions. Thank you so much.
Thank you, Dr. Hussein. I think, over the last hour and a half, we shared a lot of information. Thank you to all speakers. Now we'll move to the questions and answers. We have plenty of questions here, and we'll try to go, as brief as possible. But I think those questions probably may lead to more discussions here. So, I have the Q&A question and answer list here, and I'm just, I scanned through them and I found most of the questions, or all of them, are good questions. So I'm just going to go according to the time they were posted. So the first question was, all antivirals have been tried out on unvaccinated people. So how effective are they with the vaccinated cases? So I would assume that the vaccinated patients or patients are usually a less complicated presentation. So, how do they perform? I don't know who wants to take. I don't know, Peter, you want to take that?
Yeah, maybe I can start. So of course, the trials were actually done, as mentioned, on the unvaccinated people. But we do actually have patients who are vaccinated, maybe at a high risk. Those with the immunosuppressive settings, patients, with cancer or other type of settings. And so, of course, it's not systematic tested in those individuals, but we know that vaccine is less protective in those individuals. And the antivirals are independent of vaccine because the mechanism is completely different. And so I think it's useful to consider the antivirals in that type of setting as well.
Another question, and I think that's for you again, Dr. Liu, which is the treatment of COVID-19 in post-transplant patients. So post-transplant patient, yes, would you treat them differently? You know, they're immune compromised and then they get the infection.
Yes, so, you know, for some of the hospitalization aspect are similar to what we talked about earlier. Major difference are some of the antivirals, you know, have major interactions with the immunosuppressive agents. You know, for example, Paxlovid does actually affect the chromosomes levels and things like that. So it makes it more complicated. And the general approach is that we will start out more with remdesivir, maybe monoclonal antibodies, you know, much less interaction, you know, with the immunosuppressive agents. But if we do decide to use antivirals, then we just have to monitor the levels very, very carefully because there will be interactions.
And Peter, just again, with these immune compromised patients, post-transplant, either it's a cardiac or renal, do you use a different protocol when it comes to testing or, you know, to precautions than the normal population?
Yes, so I think in a lot of settings, for example, the booster doses, you know, are more accelerated in this group of patients, and because we know that the excuse me, the antibody levels produced are lower because of underlying conditions, and we are much more cautious in terms of for example, you know, protective equipment, you know, sort of isolation if there are any potential exposures, and generally rely more on PCR testing rather than, say, rapid antigen testing, just so that we are not missing true infection.
Great, thanks. Dr. Hussain, there's a question around the anticoagulation, and it says anticoagulation patients not hospitalized but have pneumatic patches and normal oxygen saturation. So they have some pneumonia, but normal oxygen sat and a mild D-dimer elevation. I know this is a kind of specific scenario, but I don't know if you would anticoagulate such a patient or not.
Well, based on the CDC recommendation, they recommend against anticoagulating anyone who's not hospitalized.
Great. So not hospitalized, you'd not anticoagulate. So what, okay, I mean, I think those scenarios that you discussed, say, you know, that's Afib or renal failure with Afib and so on, those are kind of different scenarios. So those ones they need for their primary condition, but straightforward COVID, no other reason or no other indication to be anticoagulated, no anticoagulation is needed. Another question comes on the cardiac complications. So the question says, when do the cardiac complications appear? Is it during or kind of care post-infection? So we talked, I mean, we had a spectrum of, you know, of the complication that happens early on and that persists on the long term. But my question, I mean, with this is, you know, a myocarditis, and this can be for, I don't know, Dr. Yusuf or Dr. Peter, you know, you have someone who come, like the cases that are presented, you know, they come with a myocarditis, and when do you, you know, follow them up? Do you say, I'm going to repeat the MRI, say, in 6 months or in 3 months? You know, is echo enough? You know, is there a protocol that's developed for those patients that you would go aggressive after them? And then the treatment, is it the same as you know, any patient with the myocarditis, kind of cardiac systolic dysfunction, or would you add anything different? So yeah, it's kind of complicated question, but
maybe
follow up and management.
Yeah, maybe I can start, and but you know, so welcome any discussion. Of course, there's no set answer for this, you know, because this is all new setting, and we are learning at the same time. We do have a protocol because we're doing the follow-up registry for these patients, and so we tend to get MRI, you know, more acutely if we can, as you know, indicated by the wonderful cases. You know, the cases are just amazing, and but then we tend to actually recommend a follow-up MRI. And so generally in about 2 months, if the patient is very, very stable and the patient is doing well. And in terms of a treatment, of course, again, you know, there are no trials and no data. So what we tend to do is that for the milder cases, what we tend to do is, you know, treat with, again, not based on evidence, you know, sort of anti-inflammatories like colchicine or, you know, ibuprofen. Not sure, you know, whether it helps or not. Patients tend to get better anyway, you know, in a lot of those situations. And we tend to follow the troponin as well if there's a troponin elevation, you know, just to make sure that they do actually return, and that the majority of heart function recovers. So that's really the nice aspect. And but if they are super sick, you know, and as a nice case illustrated, then you kind of take out all the armamentarium, you know, including hemodynamic support if it's needed, you know, to make sure that the patient can actually get through the tough period. Because again, you know, if they can be supported, they tend to do well as well. So it's worth all the effort.
Do you have sorry, Dr. Liu, just a quick question. Do you have a protocol at your institute for steroids or, you know, for specifically for myocarditis and IVIG in those patients? Or?
Yeah, no, so the way, you know, again, no, I guess no recommended protocol, but we kind of, because we're in a registry, so we kind of have people at least follow some of these. Yeah, so we do the first stage for most people is anti-inflammatory, you know, that could include high dose aspirin or ibuprofen and colchicine. And generally we'll do that, you know, for about 3 to 4 weeks until, you know, patient settles down. But if the patient is not responsive or has high risk features, you know, for example, very high troponin elevation, you know, very, very significant changes on MRI or cardiac dysfunction, then we may consider, you know, sort of next level. That could be, but generally we tend to reserve IVIG and steroids, you know, for patients who are quite sick, you know, let's say they need to be in the ICU type of thing, you know, very similar to your protocol there. Yes.
Thanks. Any comments from the rest of the panel? Please feel free, you know, to start.
I have a comment, but I see Dr. Ani is eager to speak. So Dr. Ani, you're on mute, Dr. Ani.
You're on mute. We can't hear you.
Sorry. Okay, so I was too excited. So I'm seeing post-COVID, these long haulers coming in with fatigue. I hope you can hear me now. Fatigue and shortness of breath. So I'll do CPAT analysis with stress echo. And I'm looking at diastolic dysfunction, and I'm actually, what are your comments on seeing or looking at diastolic dysfunction in these patients? That's new diastolic dysfunction post-exercise even, you know, immediately after exercise. A lot of people don't look at diastolic dysfunction in a stress echo setting. So any comments on that, gentleman and lady?
Thanks.
If I can just, go ahead.
So not getting into the diastolic dysfunction because I don't really have experience and I haven't noticed lots of diastolic dysfunction in COVID patients, maybe more related to age than I cannot prove it's related to COVID itself. But when it comes to myocarditis in COVID or myocarditis in general, we start by echo. So there is troponin, coronaries are fine, we do the echo. If there is generally, there is no dysfunction, no LV dysfunction, and there are no arrhythmia of any sort, we don't tend to take the patient to the MRI and we try to reserve that slot for someone who really needs it. If there is an LV dysfunction and or arrhythmia, then we want to study the fibrosis pattern as soon as we can, probably as soon as the patient is COVID negative, just to have an idea on how much inflammation, how much edema and fibrosis there is. And then it depends also, and we follow these patients for a month. in a month or two, if the echo is completely normal and there are no palpitations, I don't really advise to repeat the MRI, but only if the echo still shows that there is LV dysfunction or patients come in with new symptoms, fatigue or shortness of breath on exertion or palpitations, then I would want to have another look at the fibrosis pattern.
Great, thanks. Thank you, Dr. Yusuf. Another point, downregulation of the ACE2 receptor function in COVID-19. And we saw the retrospective data, Dr. Liu, that you shared with us, and that was reassuring. I know there's an ongoing prospective study that also you highlighted, the COVID-RASI trial. And while waiting for that result, what's your message?
Yeah, so there are trials that's finished on ACE ARB withdrawal. So ours is an add-on, for protection. And the withdrawal shows that it's actually very safe. And so the general thinking at the present time is that it appears that these agents potentially may have some benefit. So for example, if a patient has another indication, whether that's for hypertension, for presence of coronary artery disease, for diabetes, they would actually have a benefit for this as well. And so if they have a COVID in that type of setting, then people tend to actually, preferentially use these agents. But otherwise, if there's no indication, right now we tend to enroll them into the trial.
Great. Another point is, without symptoms, and I guess, this question comes in, but I would answer it, is the question says asymptomatic COVID positive patients, they isolate themselves at home, so mild symptoms or no symptoms. Would you do any workup or any cardiovascular workup for them? And my suggestion or my take would be not, if they're not symptomatic. And I don't know if any of you would address it differently. So asymptomatic, mild symptoms, isolating themselves at home and without any, cardiovascular symptoms. So basically not, you don't have to do any aggressive workup.
I think it's very hard to predict who will have a bad outcome and who won't. We don't have any sort of prediction models, and most of our patients are young. So unfortunately, I don't know if Dr. Peter, if you have any data about, certain patients that we need to, that are more prone to having cardiovascular outcome or not, then, if there's anything else I should do.
Definitely.
Again,
But
I would just, before Dr. Liu answers that, I would like to propose thinking again about that pulse cardiac test, right? With those multiple inflammatory markers. I think that's very helpful in determining who's going to have. And somebody asked a question about and what does it predict, right? And but I think that this pulse cardiac test is far more beneficial than that.
Excellent. Any comments from the members, or go to another?
Yes, commenting.
Yeah, I think Dr. Hussein, have a question. Answer.
Yeah, commenting on Dr. Zubaidi's question, someone who has mild symptoms and he's home quarantined, should we do a cardiovascular workup? I think the answer is no, with just one probable exception. And this is open for discussion. Competitive athletes, because these guys, if they have evidence of myocardial injury with some troponin elevation, ideally they should not go into competitive sports for maybe 6 months. And the media is now talking, and you're seeing players in the region and outside, and they die suddenly. And they wonder, why is that happening? And we can hypothesize that if it's a COVID infection with some subclinical myocarditis that we did not detect, and they go back to participation, then this can be hazardous.
Right.
Yeah, so I tend to agree. Yeah, so for the high risk, particularly, in a very, very highly competitive setting, that type of screening is helpful, because you do pick up the myocarditis, in a number of these patients, and they'll be. And then the other thing to keep an eye on, and I don't think we should routinely screen people at the moment, but there's just an epidemiological data that just came out in the last week or two, in which younger patients, who's got COVID, right, actually end up having higher incidence of new diabetes that's actually developed. And so I think we don't quite understand all this yet, but just to keep an eye on it. And so, patients where you may be worried about, you may just have a follow-up visit. Yeah.
Excellent. So another question is how do you know that the STEMI patients was related to COVID, since COVID now is common anyways? And that question, I think, Dr. Asima, you showed us a case, with the two coronaries that are occluded. So, is it part, or is there a way to differentiate? Is this related to COVID, or is there an underlying atherosclerosis that triggered that MI? I know it's not as straightforward, but
I wish I knew. I think one thing would be if there was flow to do an Ivig study or an OCT and look for atherosclerosis or plaque burden. But in this case, unfortunately, there was a very high thrombus burden, so it's hard to differentiate.
Right. The other unusual in this case is, and we saw it, I saw it in a few cases during the epidemic, is two culprits. And this is very unusual, where you see two vessels occluded at the same time with the usual STEMI. So that's why we thought this is related. I mean, the patient was a COVID positive, his chest X-ray was bad, and then two culprits at the same time. So there is something extra on top. If there's an atherosclerosis, maybe it was there, but we thought there's. Dr. Hussein, I mean, you're an intervention cardiologist and you're busy the primary PCI site. What's your take on this?
Yes, we see we see two phenomena when the COVID is on the rise, and these phenomena tend to decline when COVID declines. The first phenomenon is MI, MINOCA, myocardial infarction with no occlusive disease. That's number one. And the second phenomenon is a thrombotic occlusion with minimal plaque. And once COVID goes down, these two phenomena tend to go down.
Right. Thank you. Any role for IVIG in treatment of myocarditis? I mean, I know we highlighted this one, but again, just a very, brief message.
If I can start, yeah. So the only data, obviously, was IVIG are in the younger population. So it's actually been clinical trial to show IVIG is effective in that type of setting, and not much data, obviously, in the older or in the COVID setting. But I think it's reasonable, given that if we know that these conditions have a very high inflammatory burden, and that especially when the patient is not doing well, and I think the treatment the patient received are quite reasonable. The other aspect will be hemodynamic support if the patient truly has a major hemodynamic compromise. And but a good outcome obviously is what we're looking for in all these patients. Thanks.
Dr. Asima, one of the audience, or one of our colleagues in the audience asked, he questioned the need for coronary angiogram in your second case. He thought this is straightforward pericarditis. So the workup of ECS in a COVID population versus not. I know already you shared with us the logistics on transferring this patient back and forth to the scanners and so on. But do you do you work them differently, or why did this patient receive a cardiac catheterization?
I mean, in general, if a patient is having chest pain with ST elevation, pericarditis, we tend to use it as diagnosis of exclusion after the fact. If there's a STEMI or acute occlusion of an artery, we try and open the artery first. If then we find the arteries open, we can take a deep breath and start and say, okay, what else could it be? Yeah. And this is generally what we do in most of our patients.
Thank you. No, sometimes, pericarditis or ST elevation and a chest pain sometimes not easy to, to differentiate, and in STEMI databases, or, you get about 15%, 10 to 15% of the population, they end not having any occluded vessels. So mild or, mild disease. So sometimes based on the clinical presentation, it may be difficult to differentiate. And I think COVID is even more clear. Dr. Annie, in your patients who had extended monitoring, when is AF more common, during waking or sleeping hours?
That's a great question.
We're away from COVID, but I think.
Is it with COVID in COVID patients? I mean, I see AFib across the board. I mean, I can't differentiate on that one. No.
Right.
And they're highly asymptomatic many times.
Great, thank you. So another question, and I guess for Dr. Hussain, how long would you give anticoagulation in mild to moderate cases? And we talked about this early, but.
Well, if there's no DVT and there's no atrial fibrillation, then the guidelines are talking about either 14 days or discharge. So the maximum is 14 days. And by the way, there is a recent study published in The Lancet, maybe a few days ago, on rivaroxaban for those kind of patients. But I didn't mention it because the study is small and it was open label. It was 300 patients, so we cannot derive conclusions from that. But it showed that there was a tendency to lower bleeding compared to low molecular weight heparin.
Great, thank you. Dr. Yusuf, the patients who had fibrosis after myocarditis, I mean, here the question says, do you use antiarrhythmic drugs? We just want to clarify that. And
it's not because of the myocarditis that we used antiarrhythmic drugs. It's because of the VT. Patient had a cardiac arrest, VT cardiac arrest, and that's why we used it. And then we tried, and then we had a long discussion, and because of the severe fibrosis everywhere, with the event, with the young age, with the severe ejection fraction, systolic dysfunction, both LV and RV, the patient had an ICD as secondary prevention. And it's not really related to the myocarditis. It's really related to what happened later on. And don't forget the patient, that young patient initial presentation was syncope. He had loss of consciousness. So that was the major factor in the decision.
Great, thanks. Thank you, Dr. Yusuf. Is there any evidence, this is from Dr. Yusuf, is there any evidence of T-cell infiltration in the myocardium of patients with COVID-induced myocarditis? And if so, should it be treated with steroids, much like autoimmune myocarditis? I know we talked about the steroids and the treatment, Dr. Liu, but the pathophysiology there, what does it show? What kind of myocarditis on under the microscope?
Yeah, so for the COVID myocarditis, as kind of briefly alluded to, a lot of it is actually endotheliolitis, so it's actually inflammation of the vessels, and that's a part of the reason, we see certainly the microvascular, macrovascular complications, very consistent with Dr. Hussain and Annie showed. But for the heart itself, the virus tend to actually stay in macrophages. There are T-cell infiltration, but the numbers are much fewer than the classic myocarditis. And so this is the reason I think that we would probably, sort of go with more traditional conservative treatment. And then, if there are more aggressive evidence of deterioration, then we actually move rather than, sort of go very early on, because we think that it's more important to deal with the endothelial dysfunction, than the T cells.
Another question: patients who are who received the first dose of a vaccine and they developed a myocarditis, the second dose, do you give it differently than the rest of the population? Is there any specific tests that you would run, and would you spread the dose or give it delay it?
Yeah, so we've been tracking this quite carefully and looking at both the global data and also our own Canadian data. And so the data appears to be the following, and that is that the closer the two doses are, the higher the chance for this second dose to induce myocarditis. And then the other thing, which is really interesting, because in Canada we mix and match, because we didn't have consistent supply. If you had a first dose as Pfizer and second dose Mrna, you have 25% the chance of having myocarditis, way higher. So this is a really interesting phenomenon. So and in fact, Mrna knows about this. So sometimes now they lower the booster dose, to half the original dose, in a number of countries as a result. Yeah, so, but however, if you had a Pfizer dose before and then subsequent followed, let's say with the Johnson & Johnson or non-mRNA and vaccine, you almost never see myocarditis. But the other thing, however, is the interval. So if you actually, the original interval recommended was like a 3 to 4 weeks, and we saw that a lot in the US, and you get a lot of myocarditis, we saw earlier in terms of on the second dose. But if you actually stretch that out, and so, let's say 2, 3 to 4 months, the second dose then has very few myocarditis. Yeah, so what we tend to recommend is that if you had first time, had a potential risk, you either stretch out the interval or, switch to certainly stay with a Pfizer and not go to a Moderna. And, or if you have access to a non-mRNA vaccine, take that, so those are all the options available. Yeah.
Can I ask one more question?
Sure.
I have 2 patients with myocarditis, and they asked me, should I get vaccinated or not? And if I am getting vaccinated, what is my risk? So
yeah, so
have a history of myocarditis.
Yeah, so this is always I call the individualized risk versus benefit, and so if they have a very high risk, and there are no let's say after Omicron, no other virus coming around, then the need for a booster vaccine will be lower, right? In that situation, it's not mandatory. But on the other hand, if let's say it's the opposite situation, they have myocarditis and they have other underlying conditions, and there are sort of a new wave is coming in. In that situation, they should still get vaccinated, and so you want to make sure that they have a reasonable interval between their incident and the vaccine, and then watch them very carefully. Just make sure they are looked after.
Great. There is there's a lot of questions, but I am pushed to get to get to the end of this webinar because of the time. It's already 9 o'clock. So already I took 2 minutes out of your time and out of our colleagues' time. Apologies for our audience because we cannot answer all the questions. At the end, I would like to thank all the speakers, all my colleagues here. It was very informative, a lot of information to digest and absorb. But I am sure and still we are learning, either it's in the acute phase of cardiovascular complication of COVID or the long-term complications. Thanks to our attendees and audience online for their interaction. This would not have been successful without the interaction that happened. Thank you again. Thanks to our the support we received from our colleagues from Pfizer and to the organizers, the event organizer, our colleagues from ICOM. Thank you all, and have a good night or good morning, Peter.
Thank you.
Thank you.